Right, okay. So this was a 39-year-old lady and that came to us with some vague, unspecific problems. And she told us that she has hearing problems for quite some time, and that she also had been diagnosed as glucose intolerant, but really never really developed diabetes yet. However, her brother, mother, and two uncles had problems with hearing and diabetes mellitus. She had problems with color vision and night vision, and she also told us that mother and her two brothers died young due to cardiovascular problems. So it's quite interesting, familiar diagnosis. It's hearing problems, it's glucose intolerance, it's diabetes in the family, death due to cardiovascular problems. Okay, now this is what we saw. Her visual acuity was full in both eyes, color vision was somewhat down, and she had this pigment epitheliopathy, which you could see here on OCT and autofluorescence, and probably some loss of sensitivity in these areas on the visual fields. So you have pigmentary changes, which are probably causing some of this vision loss, though. So you want to do electrophysiology, and electrophysiology did show some of the central loss and some cone dysfunction, but not really severe. Okay, and so we were thinking whether this could be some cone dystrophy or some sort of pattern dystrophy or something like that, and we said, okay, let's observe. And she came over 2 years, she came back, and she actually did progress to some extent, as you see. This is in 2013, 2015. And there is some progression also, but visual acuity is still good. So is there something already that rings the bell? Yes? Yes, yes, that's one possibility, and we're very, very close to the diagnosis. And at this time, basically, she was okay. She didn't have glucose. She had glucose intolerance. She didn't have diabetes yet. But I agree with you. Now, what happened to her quite insidiously? In a year later, she was hospitalized in a neurology clinic due to headache, vomiting, right-sided homonymous heminopia. And what MRI showed is ischemic stroke in left parietal occipital region, which did not respect vascular, vascular regions that are expected in vascular stroke. So it's crossing over vascular regions. So at this point, I agree with you that MEAT would be a diagnosis before, and at this point it is MELAS. MELAS stands for lactic acidosis and deafness, and actually it is a mitochondrial encephalopathy which causes lactic acidosis stroke-like episodes, and it has this distinct mutation, which is the same mutation as with MEAT, actually. And she had 2 additional strokes later on. So she is now hemiparetic, and she's not in a good condition. And interestingly, her brother, he has also hearing problems. He has diabetes, and he is 10 years on insulin and has also rather poor color vision, but is probably anomalous trichromat and has some pigmentary deposits, but not really very much. And he actually does fully comply with the diagnosis MEAT. So whether or not he will develop MELAS from MEAT, we don't know, basically. But it's something to keep in mind if you have some patients that have hearing problems, diabetes in the family and some pigmentary deposits that they may be in danger to develop serious neurologic symptoms and stroke, and they should be warned like her brother.
What's the cause for the hearing problem?
Excuse me? It's a genetic cause of the hearing problem as well, so it's affect the
neurosensory
part, yes.
Neurosensory deafness. So we're talking about different phenotypes of the same genetic background?
Yes, there's the same gene, and it's two phenotypes in the family.
Okay.
Yeah.
Any questions from the audience? Quite rare, I think. Quite impressive, quite rare.
Thank you.
Okay.
I have more cases, but...
Do you have one more case? We still have time, eh? We have 10 minutes.
Do we?
Yeah. Yes. Okay, if you can spare us one more case, it would be ideal.
Okay, this is a rather long one. Maybe I'll skip this one. And
you can either cut it short or show us the short.
Go for one which is very short and fascinating. It was very... we saw it for the first time, actually. So this was 65 years old gentleman that came to us with history of 3 weeks of progressive visual disturbances, and actually at that time he was otherwise normal. He didn't have any neurological signs, everything was normal. Over time of, let's say, a week or so, he started to change. When he was hospitalized in our hospital, he started to forget things and behave a little bit unusual. And visual fields showed some inferior incongruent homonymous quadranopia, which, okay, we wanted to test everything, whether there's something that causes compressive lesion or whatever, and vision went down to 0.2. His fundus was perfectly normal MRI, and some progressive personality changes occurred. So what would you do? MRI was normal, yes, normal. At that point, it was normal. Yes. Electrophysiology was done. And what it showed is that full field ERGs were normal, pattern ERG was slightly subnormal, N95, and VEPs were almost extinguished, delayed, and prolonged. And normal MRI. And personality changes that deteriorated even further. So he actually once left the hospital and couldn't find a way back. And that happened within a week, yes.
What was his vitamin B12?
Excuse me?
Vitamin B12
we did that and it was normal, yes, very good. Okay, so what we did is lumbar puncture. What we found is T-tau proteins, which actually tells you that this patient actually has prion disease, so Creutzfeldt-Jakob disease.
The mad cow's disease.
Yeah, you have two forms. Some is transmitted from that meat, but it's actually a genetic cause of that. So Creutzfeldt-Jakob disease is a terrible disease. It's spontaneous encephalopathy. So you don't see anything at MRI in the beginning. And then over time, you will see changes, but actually he was actually unable to follow any rules anymore, and he died in 2 months. So that was a...
Exactly one case like that a couple of years ago. The clue was going on. Somebody knows that and the patient also died.
Yeah, yeah.
Exactly the same pattern.
Yeah.
Can it start wherever the brain? This was probably...
Yeah, it's diffuse. It's diffuse, really. Yeah, we also thought maybe it's also optic nerve may be affected with these prions. So,
would an MRI later on be more helpful?
It would show changes, yes. However, at that time when you see these T-tau proteins, then you know what it is. You don't need to do it. So here electrophysiology was the only objective sign really to help us to find a diagnosis. One more?
Are you up to one more? The audience? Okay. Yes, we do. There is always enough time for professor, for invited speakers, okay?
Okay, let me then show you this.
Andreas, there's still the lunch with the experts.
Has a case. Maybe you have
I can save
case?
you my seat for the lunch with the experts.
No? Stop. It's me. Okay. Okay, one case. So I told you before, when you have a, patients that do improve and you didn't expect it, so what do you do? Look, it's a 74 years old lady, and she gradually lost vision on the right eye, and 5 months earlier on the left eye, and 14 days she was still progressing even more, last days especially, and she saw some flashing lights, and last 3 days she had some headaches, and no other signs of eventual giant cell arteritis, which we of course excluded first. So left eye was affected first, and so it was 0.5, so pretty poor vision, so the first line on the chart, and actually quite good color vision, unexpectedly, positive relative afferent pupillary defect. It was disc edema with hemorrhages, and right eye 0.5 and full color vision, normal disc. So we thought, well, we excluded temporal arteritis. We thought it's probably non-arteritic. No treatment was given, and she improved over time, spontaneously. So, whoops, how could this happen with non-arteritic ischemic, anterior ischemic optic neuropathy? And she improved quite well, actually, to 0.4 on this eye, that was 0.5, and to full vision on the right eye. So both eyes improved spontaneously. So what would you think about? Okay, we did CRP, SR was non-specific, but serum ACE was elevated, but not that much again. But pathologists said it's probably not sarcoidosis, whilst RTG, chest X-ray actually did show streaky changes in lower lung lobes. So she also had some Lyme increased IgM, which was interesting, and infectology decided that they should do doxycycline treatment. TBC was negative. ASR actually did increase, and then rheumatologists said, again, whether or not it could be, but they said it's probably unlikely. Temporal arteritis is unlikely. CT, CTA of head and neck were normal. CT of the chest was showing bilateral increased hilar lymph nodes.
Did you do any temporal artery biopsy?
Yes.
Haven't done.
Yes, and that actually showed.
You did or you didn't?
Yes, actually showed that this patient, which basically improved very well, didn't have any other ocular or systemic signs of sarcoidosis, but actually was confirmed sarcoidosis. So she was treated and her vision actually improved, and she had another attack in between, but then this, what you see is disc edema that actually resolved over time with treatment, and the changes that you would expect on the fluorescent angiography, like candle wax drippings or anything, were not there. So it's a really unusual case. First, SAC was normal, and then CT of the hilar lobes actually did show that she possibly has sarcoidosis. So this is something you should never forget, that sarcoidosis actually could strike in a very sort of advanced age of 70s, even actually without any other clinical signs. So neurosarcoidosis is something that you should suspect when you have bilateral hilar lymphadenopathy. And if you do have some sort of spontaneous improvement that you didn't expect.
What about his Lyme cirrhosis?
Well, they said it's in the end it's non-specific. So even if SAC was normal, then go on and check for other things. Even if there's no other signs, no skin changes, no other changes. So this would be this. Thank you.
Thank you, Professor Ηawlina. I want to thank all the speakers. This closes the first session of Pediatric Stabilis with Neuropathology. Everybody is welcome to have a coffee break, and we'll be back at 12:30. Thank you.